Hi, and welcome to the SCD Lifestyle Solution Podcast 29. I'm Jordan Reasoner, and I'm here with my partner in crime, Steve Wright. What's going on, buddy?
Hey man, I'm excited to be here again. Show 29. We're really close to 30, so it's a good day.
I know, man, I'm really excited about our guest today. Today we're going to have on the show Dr. Leo Galland. And when I first came across Dr. Galland's work, it was back when I was completely stuck, wondering if I should even try SCD or if it would even work for me. And I couldn't find any evidence that it actually worked for other people either. But I finally stumbled across this paper that Dr. Galland had presented back in 1999, where he actually took 20 Crohn's disease patients and he tested SCD on them and actually worked for him. And he found that all 20 patients had a decrease in symptoms. And in fact, 6 patients showed a complete clinical remission. So that was enough for me and sold me on the idea that I would finally start SCD. And I was really thankful for the work that he did with that study because it's a convincing factor for a lot of people. And I want to take a second to give him a proper introduction because it's quite an honor to have him on the show today. He's internationally recognized as a leader in integrated medicine. In fact, he's the director of the Foundation of Integrated Medicine. He's authored 3 highly acclaimed books, including The Fat Resistance Diet and Power Healing. His medical credentials are out of this world. They're some of the best I've ever seen. He's been on numerous radio and TV shows. I even caught him on the Today Show explaining stomach acid to Tiki Barber and the rest of America. So I could go on and on. Dr. Galland, you have a phenomenal body of work. Thank you for all the work that you do, and especially for taking the time to talk with us today. So welcome.
It's a pleasure to be speaking with you. I have a special interest in helping people with inflammatory bowel disease find nutritional solutions to relieving symptoms and improving disease activity and outcomes.
Well, thank you so much. I've read much of your body of work, and what stands out most to me is your insistence on putting the patient back into the healing process. Can you share your story with us a little bit and how you came to become involved with integrated medicine?
Well, basically, I'm a perfectionist, and I was not happy with the results that I was getting using the kinds of conventional medical tools with which I'd been trained. And I'm talking about 35 years ago. And so I started exploring ways of doing better, basically. And it was totally based upon improving the outcome of care. And I started exploring aspects of healing that were not being addressed by the modalities that I'd been trained in. I had a very good training in internal medicine at Bellevue Hospital, the NYU Bellevue Medical Center. I had taught internal medicine and family and community medicine, and it became clear to me that there were things that impact on the health of people and on their long-term prognosis that were just not being addressed. And so I became interested in nutrition, which seemed to me to have a clear impact on recovery and immunity, on patterns of exercise and lifestyle, and on the way that personal interactions and the way that people thought about their problems and motivation for change. And there was nothing called integrative medicine in those days. And so I started doing my own research and began meeting people who had similar interests. And we actually formed a group called the Academy of Integrated Medical Studies, which met every 2 to 3 months in the Berkshires. I talk about this in part of my book, Power Healing, actually. And as I began to apply some of these methods with patients I was treating, I started seeing problems that I had not been able to address previously improve. And so I looked back at what is it that I'm now doing with patients that is helping me achieve such better results. And I realized that there were a few things. The first principle was that I was just looking at aspects of the patient that had been ignored. In fact, I tended to get the best results in people who had seen several good specialists, because then all of the kind of conventional issues that need to be sorted out when you have a new patient had already been sorted out quite well. What the specialists had ignored was the person. That is, they knew a lot about the disease, but they had really ignored just basic aspects of who this person is, what the person eats, what kind of social relationships the person has, what the environment the person lives in is like. And so by looking at those aspects of the person, I found I was dramatically able to enhance the outcomes. Part of that process led me to be particularly interested in the gastrointestinal tract and its impact on general health. And I found that if I really addressed GI health as one of the primary issues, that a lot of other issues, a lot of other problems would begin to improve. And so that started to become a focus of the work that I was doing in working with patients in general. Along the way, I got particularly interested in helping people with inflammatory bowel disease because I found that the nutritional therapies in particular were so important for so many of them. And the conventional approach was just based upon fairly toxic immune suppressive drugs. If first-line treatment with drugs like Azicol didn't work, and it just seemed to me that nutritional therapies should be the first-line approach for inflammatory bowel disease. And there's been more and more evidence of that, and the research has continued to support that. As a result, I was asked to write a textbook chapter on integrative therapies for inflammatory bowel disease for the textbook of integrative medicine, which was edited by David Rakel. And that was the second edition. I created that chapter about 4 years ago, and at that time I reviewed all of the publications, all of the scientific data on nutritional and integrative approaches to inflammatory bowel disease. I've just, about a year ago, redone that chapter for the third edition, which I hope will be out soon. I was amazed at the amount of new research that had come out within that year. And there's even more. I've been keeping track of it on a weekly basis, and there's a substantial amount of research that I think is going to really be beneficial to patients with Crohn's and ulcerative colitis. And you just don't read about this unless you search for it. All that you read about is the latest indication for the use of Remicade, for example.
Right.
Okay, all right. So that's a long answer to a short question.
Oh, that's great. I think that I read much of that chapter on the website for the Foundation of Integrative Medicine.
Right.
I'd love to dive into that a little deeper. So let's talk about your treatment of IBD and how you approach it, and also how the specific carbohydrate diet plays into that.
All right. Well, let me let me just give you my background on the specific carbohydrate diet.
Sure.
About 20 years ago, I saw a patient with Crohn's disease who told me about the specific carbohydrate diet. She had heard about it from a friend of hers in Canada. And so I contacted Elaine, spoke with her, liked Elaine a lot from the conversation we had. The patient did fantastically well on the SCD. and I began applying it. I got copies of Elaine's book, which was called Food and the Gut Reaction at that time. It was self-published. And I began using that diet with patients and seeing great results, not only in patients with Crohn's disease, but also in some individuals with irritable bowel syndrome. And I hadn't as yet started to apply it to other conditions. Yeah, actually ankylosing spondylitis. I had a patient with ankylosing spondylitis who did very well with it. It's very similar to a diet that was developed by Carl Ebringer, a rheumatologist in England who has treated many patients with ankylosing spondylitis, which is it's an inflammatory disorder of the spine that is sometimes associated with IBD. And so Ebringer had worked that out on his own. What I loved about Elaine's book was that it laid everything out for patients in a way that they could just grasp and work with on their own. So I began, for 30 years, I've lectured to other physicians about topics in nutritional and integrative medicine. So I began advocating that people read Elaine's work and incorporate the specific carbohydrate diet into their dietary approaches. One of my friends, Ron Hoffman, became an avid admirer of Elaine's work and started using the SCD frequently in his practice with excellent results. One of the most dramatic cases that I had was a patient who was actually written up in Newsweek. This would be about 1996. This was a man of about 30 who had severe Crohn's disease, and despite maximum medical therapy at that time, this was before Remicade, but he was on steroids. He was on 6-MP. He was very ill with high fever, 6 bloody bowel movements a day. He was losing weight. He was passing kidney stones. And his sedimentation rate, which is a marker of inflammation, was 90, which is very high. Within 3 weeks on the SCD, he had no symptoms. His sedimentation rate had fallen to 5, and he was able to discontinue all of his medication and stay in remission for a long period of time. Eventually he said, look, I've got to be able to eat pasta. I come from an Italian family, and that reactivated his Crohn's disease, but at a very mild level, so it was readily controlled with the available drugs. So that was, my experience with him was a real boost to my recognition of the power of the SCD, especially for patients with Crohn's disease. Now, while she was alive, Elaine referred to me a number of patients who had not done well on the specific carbohydrate diet, and they were all people with ulcerative colitis. And one of the things that she said to me, and I don't know if she ever wrote that or published it, but she said that in her experience, the diet worked much, much better for people with a diagnosis of Crohn's than for people who had been diagnosed with ulcerative colitis. And that has definitely been my experience. Although having said that, I want to say that neither Crohn's disease nor ulcerative colitis are single diseases. It's widely recognized by researchers now that Crohn's represents several different disorders that have produced similar kinds of appearance and pathologies. At some point over the next decade or so, I'm sure that the differences among patients with Crohn's disease will be classified in a more useful way than they are now. The experience has generally been that dietary therapies work best in people who have disease of the small intestine as opposed to only the large intestine, and that they work best for people whose disease is deep, that is, who have fissures and fistulas, rather than just superficial ulceration, which looks more like ulcerative colitis. But even that rule doesn't apply, and that's only to the extent that that rule applies, it applies only for diet, not for other nutritional therapies in the form of supplements. So just to get back to the question that you asked, the first question that I want to understand is, does this patient appear to have a picture that's consistent with Crohn's disease or a picture that's consistent with ulcerative colitis? Because for Crohn's, I absolutely believe that the specific carbohydrate diet should be the first approach to treatment. And because 70 or 80% of people who are told they have Crohn's disease will show a beneficial response with the specific carbohydrate diet. They follow it, and as Elaine pointed out in both of her book, you have to be really fanatical, especially at first. For the people who don't respond to the specific carbohydrate diet, there are a number of other treatment approaches to take, and I'll get to them in a few minutes. What I wanted to say about the SCD and Crohn's disease is that some of the people that respond best to the SCD do their best when the only treatment that they receive nutritionally is the SCD, without supplementation. There's a tendency in integrative medicine to decide that, well, if someone has inflammatory bowel disease, they should be on probiotics and glutamine. And I hold off on supplements until I see how the person is doing on the SCD. And then I begin to add them slowly. I do blood tests to look at their status with regard to vitamin D and zinc. I also am interested in following parameters of inflammation, the albumin level in the blood, the C-reactive protein, the sedimentation rate, the way they metabolize vitamin D, which is done by measuring the two different forms of vitamin D. When I start supplementation, it's usually with zinc or vitamin D. Probiotics, I think, are very unpredictable in patients with Crohn's disease in particular. And the most consistent response that I've had that's been positive has been in people who have diarrhea and are treated with Saccharomyces boulardii, which is a yeast. But I've seen a lot of patients with Crohn's get worse with probiotics, and so I think that's the decision to use probiotics is one that I make only after I've started other treatments and assessed the way the person is responding. And as a general approach, I like to make one or two changes at a time and see how that affects the person's symptoms. Then make another couple of changes and work in a slow and methodical fashion. When the symptoms are well controlled, then I want to follow blood tests. I want to look at indicators of inflammation in the blood, the ones that I've mentioned. And if there's involvement of the small intestine, I will at some point do a small intestinal permeability test, which is a good indirect measure of inflammation in the small bowel. Now, with ulcerative colitis, I tend not to use the SCD as first-line treatment. For one thing, I've only seen a couple of patients with ulcerative colitis in whom the SCD was the game changer in their care. And I know that there are reports on the internet of people with ulcerative colitis doing very well on the SCD. The studies that have looked at the impact of diet on ulcerative colitis have generally shown that high fiber, low animal protein diets are associated with a reduced incidence, and that red meat and alcohol are associated with an increased risk of relapse. And there are a number of studies using prebiotics and fiber in ulcerative colitis that have shown positive results. Those are the kinds of things that have never, that have not been convincingly shown for Crohn's disease. And so I think there is a real, in terms of first-line treatment, there's a real separation in the dietary approach to ulcerative colitis and Crohn's disease. With Crohn's, it's SCD, relatively high protein. With ulcerative colitis, I tend to go towards a vegetarian plus fish diet and high in fiber, and see how the person responds to the diet over the course of, let's say, 3 weeks, and then make the next decision. One thing that I think should be avoided by all people with IBD are the usual vegetable oils, the high omega-6 oils like safflower and sunflower and corn oil. Their consumption has been associated with an increased risk of developing IBD and an increase in inflammation in the colon, both with Crohn's and with ulcerative colitis. I think that for IBD patients, they're very pro-inflammatory. The only oils that food oils that I have my patients use are extra virgin olive oil. I may supplement their diet with fish oil. I don't believe that fish oil works very well in Crohn's disease, but there are numerous studies showing benefits of fish oil in ulcerative colitis, and I'll tend to push the fish oil doses up pretty high. The main problem with fish oil is that about 20% of people taking it will develop diarrhea, and so that can be a limiting factor.
That's fascinating. I appreciate that you shared the differences in how you treat ulcerative colitis versus Crohn's disease. I've never heard that specifically talked about in that way, so that's helpful.
That's been my experience, and that is something that was not really in the first chapter that I wrote, but in the new chapter that is going to be in the 3rd edition of Rakel's textbook, that will be reflected there.
Okay, great. Okay, so I want to dive in a little deeper in your treatment of Crohn's. In the integrated approach to gastrointestinal disorders, you explain that you kind of have 3 phases, and this is also cited in your study of the 20 Crohn's patients that a lot of SCDers kind of look to for good solid evidence. You talk about there's sort of 3 phases of SCD modifications that you make when patients don't respond with improvement, and I was hoping you could elaborate on those specific changes that you look for making when patients are not responding well to SCD initially.
Right. Okay. Well, the first question is, does this person actually have an adverse reaction to some of the SCD foods? I occasionally see people who can't tolerate the nut flours or dairy products. The dairy's not in the intro stage to the SCD, but I would say that after patients with Crohn's should definitely be on a low sugar diet and should avoid these omega-6 oils. If they're not SCD responders, there are a couple of possibilities. Some of them just really need primarily a very strict dairy-free diet. I once saw a young woman who had pretty active Crohn's disease. She was doing everything right when she came in to see me. I was quite impressed. One thing that she was not doing and hadn't even recognized was she was taking a whey protein drink every day. And as soon as she cut out the whey protein, her Crohn's resolved. And she thought she was heading for surgery. So I have definitely seen people in whom avoidance of dairy was the main thing that they needed to do. And the SCD will, allow certain dairy products. And then there are people who just seem to react adversely to the almond flour, and so we need to come up with another solution. When I first started treating IBD and with diet, I put most of my patients on a yeast elimination diet, and I had many patients that did very well with that. Especially if there's a history of multiple antibiotics and adverse reactions to antibiotics with regard to their IBD, I definitely look at a connection with yeast. I remember when this goes back about 20 years ago, I saw a 13-year-old girl who had an identical twin sister. The girl had Crohn's disease, her twin sister did not. The main difference in their history was that the girl with Crohn's had multiple antibiotics during the course of her life. And there was a recent study which came out and got some publicity indicating that exposure to antibiotics was a risk factor for IBD. And so I treated that girl with a yeast and mold elimination diet, plus nystatin orally, which kills yeast. She did remarkably well. And the thing that was so disappointing to me was that her pediatric gastroenterologist basically was impressed with how well she did, but had no interest in knowing how she got to be so well. And that's an unfortunate response that I've seen over and over again, which has sort of been the response of the specialist that says, oh, well, you're doing great, keep doing whatever you're doing, but no interest in understanding what it was that turned the corner for that person, which I think is one of the big differences between people that go into integrated medicine and most conventional specialists, is that curiosity to find out what was it that the person did that made the difference. So occasionally I will actually fall back on something like a defined formula or elemental diet. There is a lot of research on the use of what are called enteral feedings, especially in children with Crohn's disease, and they do very well. The enteral feedings are as effective as steroids in bringing people into remission. And so I may have to fall back to that. And there is one product that's commercially available online that I've had a couple of patients do very well with, which is it's actually a hydrolyzed whey protein formula. And if you hydrolyze the whey protein, it doesn't have the same impact as taking whole whey protein. It's called Absorb Plus. And so I've referred some patients to the website that's affiliated with that product on occasion.
Oh, that's very helpful. So I just want to make sure and summarize a little bit for the listeners when you're talking about your clinical experience using SCD, and when you run into patients that maybe don't respond, which I think you mentioned is around 50% with
15.
Crohn's.
15.
15%, okay.
Yeah.
So in that case, you'll first look to maybe pull out the dairy if they are using dairy, and then pull out the almond flour nut products, and then look at possibly going low sugar.
Well, right. Going particularly low sugar and yeast-free.
Yeast-free, okay, excellent.
Right.
And then
because there's a fair amount of fruit allowed. There's a fair amount of fruit allowed in the SCD.
Right.
So I might have them cut the fruit out and go yeast-free.
Okay, great. That's extremely helpful. I think that's going to help a lot of people that maybe aren't getting the results that they're looking for as they, embark on the diet and focus on those things. Um, and earlier you mentioned that uh, along with using SCD to treat, you also incorporate supplementation in the form of vitamin D, zinc, in some cases fish oil, some cases probiotics help. But can you elaborate a little more on some of the additional supplementation that you've had success with along with SCD when you're treating IBD?
Um, okay, right. Well, actually, people with ulcerative colitis or just pure colitis, or even superficial Crohn's colitis without fistulas, um, tend to respond better to supplementation than uh, and so especially with ulcerative colitis, I'll tend to do more supplementation. But the other thing that so yeah, other supplements that can be helpful. There's research on curcumin for both Crohn's and ulcerative colitis, indicating improvement in symptoms. I have to say, my own personal experience with that, I've been using it, has not been as good as what's in the research literature, but I'm still looking. Their folic acid or folates are something that are important for people who are taking the 5-ASA inhibitors like acetol and related drugs, because those interfere, asulfidine, those interfere with vitamin A, with folic acid absorption, and deficiencies can occur. The vitamin D has actually been shown to prevent recurrence of Crohn's disease in a controlled study that was done in Canada. Those are the main ones that I use. Occasionally there are deficiencies that occur in vitamin A or selenium, magnesium, and so I'll supplement with those. Glutamine, which is widely used in integrative medicine, has been shown not to be helpful for Crohn's disease, and in an animal model of colitis, it actually made the colitis worse. So if people are taking supplements containing glutamine, I tell them to stop. And actually, half of what I do with the supplementation is have people stop taking what I think are the wrong supplements. N-acetylglucosamine, on the other hand, which is totally distinct from glutamine, has been shown to be helpful in some case reports, and so I may use that. N-acetylcysteine, or NAC, has been shown to enhance the effectiveness of mesalamine, which is one of the 5-ASA inhibitors, so I may add that. Melatonin, I think, should be avoided by people with inflammatory bowel disease. There are case reports of melatonin actually aggravating IBD and people improving when they stop taking melatonin. It's a very potent immune stimulant of the type of immunity that's overly activated, especially in Crohn's disease. Other supplements that may be worthwhile, I'm constantly looking for things about which there are publications I'm constantly looking for substances about which there are publications in the peer-reviewed literature, and then trying them in my practice to see if they work. And one that I'm exploring right now is a product called Sedacrohn, Sedacrohn. I don't even mention it in the chapter that I wrote because I've only been working with it for the past several months. So far it's looking pretty good and has actually been tested in Germany in placebo-controlled trials where it showed beneficial effects in Crohn's disease, and it's something that's available in the U.S. and available online. I'm not advocating that people take it now. I don't have enough experience with it, but I think it's promising. With regard to probiotics, if someone's having diarrhea, I almost always start them with Saccharomyces boulardii, and if they're not lactose intolerant, the product that I'll use is the regular commercial brand of that, which is Floristore, which is the one that all of the research has been done on. This has rather remarkable anti-inflammatory effects. It can cause, Saccharomyces boulardii can be very constipating, however, so I don't use it in patients who are constipated or have difficulty passing stool as a manifestation of their IBD. I pretty much reserve my use of prebiotics for patients with ulcerative colitis. Fructo-oligosaccharides, galacto-oligosaccharides, oat bran, and other forms of fiber supplementation. There are a number of studies indicating that people with ulcerative colitis can benefit from these, and they're basically not SCD legal. I don't mix them with the SCD, but since the majority of my patients with ulcerative colitis are on a high-fiber, basically vegetarian-oriented diet, they're quite consistent with that. Those are the main supplements that I use. I do think it's very important for people to be carefully checked for infections, especially with intestinal parasites. About 20% of the patients that I've seen with ulcerative colitis are infected with parasites, and in about half of those cases, they don't even have ulcerative colitis. They actually have amoebic colitis that's chronic and has not been properly diagnosed. And so I've seen people get cured by appropriate treatment. This has been described in textbooks. Dr. Spiro, who was the chief of gastroenterology at Yale and had written a textbook, kind of a leading textbook of gastroenterology, stated in one of his early editions that he thought everybody with ulcerative colitis should receive a trial of Flagyl because when he was a fellow, he had missed a case of amoebic colitis in a patient that was only diagnosed surgically because the stool tests were negative. So I urge people to be very thoroughly tested for parasites, and I frequently use antibiotics in the course of treating ulcerative colitis and Crohn's colitis also. And patients often do very well. I even have one patient that I'm treating now, a young woman who has had probably Crohn's colitis. The diagnosis was not certain, who has stayed off all medication and in total remission as long as she follows a milk-free diet and takes an antibiotic called Bactrim, which is not even one of the ones that's commonly used for IBD. Totally maintains her in remission, and with regard to the choice of antibiotics, there is no single antibiotic that's best. Many of the GIs are now using rifaximin, also known as Xifaxan, to treat patients with Crohn's disease. Sometimes that's very helpful, but I wouldn't end the quest with Xifaxan. Now that gets out of the area of the use of antibiotics, of course, requires a physician to prescribe them. It gets out of the area of things you can do yourself in nutritional medicine. But I think it's a very important component of the integrative treatment of IBD.
That's so great that you brought that up, and I want to jump in and ask, because a lot of our listeners are wondering, we've been hearing a lot lately about DNA PCR stool testing through like metametrics, microbiology tests, but what specific stool tests do you find that that works the best with your patients when you're looking for organisms like parasites or bacterial infections?
Okay. Well, I think that looking for parasites in stool, it's basically the lab. It's a question of how good is this laboratory, and the Metametrics test is not licensed in New York, which is where I practice, so I have relatively limited experience with it. I think the idea of doing PCR testing for parasitic DNA in stool is a good one, but I can't really comment on how well the test performs. But I think the testing should be done through a lab that really specializes in the hunt for parasites, because the more time the technician spends looking and the more experienced the technician, the more likely you are to find the organisms.
I see. So is there a specific lab that you like to use in New York that you have experience with?
Well, there's a lab in New York called Jetty Katz that I use.
Okay.
They also run a test for atypical mycobacteria, which have been implicated in Crohn's. Although, again, I can't comment on the performance characteristics of that test because I just haven't seen enough positives from it. And I'm sure that there are going to be better tests for atypical mycobacteria that come along over the next 5 years. At the end of the day, it kind of becomes an empirical. The question gets answered empirically. If someone is not doing well, I will often use antibiotics and see how they respond to the antibiotics. I may start with rifaximin if their insurance will cover it. The young woman who was on Bactrim, when she first got sick, because it looked like an acute gastroenteritis, her pediatrician put her on Bactrim, and it cleared everything up really well. So that was kind of an easy choice when I had to decide on an antibiotic. Well, this one worked. Let's go back and try it again. And that is, in fact, a question that I always and more than once ask patients with IBD is, during the period of time that you've had IBD, have you used antibiotics for any reason, not necessarily for IBD? And if so, how have those affected your GI symptoms? There is a group of people who get worse on antibiotics. In those people, I strongly suspect yeast infections and will use antifungal medications, yeast overgrowth. A number of years ago, there was a woman about 21 years old who was being treated by a friend of mine out in California. And family called me up, and she was on Cipro for Crohn's disease. Some kind of parasite had been found in her stool. I frankly have never found parasites to aggravate Crohn's disease. As much as I found aggravation of ulcerative colitis by parasites, or even the mimicking of ulcerative colitis by parasites, in people with classic Crohn's disease with fistulas, etc., just never found parasitic infection to play a role, and except maybe as the initial trigger, but not as an ongoing part of the disease. And when I spoke with her, she was just getting worse and worse the longer she stayed on Cipro. So my advice was stop Cipro, go on diflucan and a yeast-free diet. Diflucan is an antifungal drug. Within a week, she was much better, and it took her a long time to fully control, let's say to get over the disease, but the process of controlling it well started very quickly with that change in antimicrobial use. So if someone has done well in terms of their gut on a specific antibiotic in the past, I will usually, if they're sick and symptomatic, try that antibiotic again and see if it works a second time. It's about a 50-50 chance that it will. And if it does, then we may continue that for some period of time. And if it doesn't, well, then we'll keep looking out elsewhere. I also want to know about antibiotics that people were on prior to either the onset of the disease or the onset of a flare-up, because sometimes that's a clue as to what needs to be done. One of the problems that people with IBD have is a dramatically increased susceptibility to the development of Clostridium difficile colitis. And especially with ulcerative colitis, that can occur even without antibiotics, but may be precipitated by antibiotics. And so if someone were on antibiotics and then developed, then their ulcerative colitis flared up, I'd definitely look for C. difficile. I think this is done in a pretty standardly now, but not every patient gets the full standard of conventional care that's needed. I don't know if that fully answered your question.
It did. It did. Thank you, Dr. Galland. We're running out of time, and I know we could probably spend days talking about this, so I just want to thank you again for your time. Your clinical experience is so valuable to share, and there's so many incredible nuggets that you've offered us today. I know it's going to help a lot of people. And I have two more quick questions to ask you. The first is, I know that personally I spent hours reading your work on mdheal.org, which is the website for the Foundation of Integrated Medicine. But what are some other resources out there that our listeners can go to learn more from you and your work?
Okay, well, I have two other websites. One is called pilladvised.com, and that has a lot of information about supplements and especially the way they interact with drugs. There are a lot of guest bloggers on that website who share their experience with viewers and users. So I strongly recommend Pill Advised. I'd written a diet book called The Fat Resistance Diet. I've had some patients with IBD who did very well with the fat resistance diet, who did not need to go to the full SCD. It's especially helpful for people who are overweight and have ulcerative colitis. I'd say that's a good resource there. There are a lot of recipes and food ideas there. And I don't remember the name of the website of the place that makes Absorb Plus, but you can find them online. That's a product that I think is worth exploring. The website that goes with it will have a lot of useful background information. I don't necessarily agree with everything that's said on that site. But then I don't have to agree with everything that somebody says in order to recognize that they have something to offer some patients. The other website I think is worth for people to explore is ovamed.org, OVAMED.org. That's a site that is dedicated to research that originally started at the University of Iowa and is ongoing in different places, related to the use of worm therapy for IBD. There have been clinical trials, some of them placebo-controlled, on the value of TSO, which are pork whipworm eggs, in modulating inflammatory and immune responses. And I think everybody with IBD deserves to know about this work.
Oh, that's great. That's some great resources. I'm very interested in the last one for sure. And finally, my final question is, I'm personally very interested, and I think our listeners would be very interested in reading your book, Power Healing. Could you give a quick overview of that book and kind of what it'll do for us?
Well, Power Healing is a book that I wrote about 15 years ago based on my experience during the previous 20 years as a practicing physician. And it's a philosophy of medicine, and with a good deal of practical information in it. But it's based upon my recognition that healing occurs because of the individual, not because of the treatment of the disease. And that treating the disease is an inadequate basis for a healthcare system. And so I developed a concept called the 4 pillars of healing, which are things that you yourself can control that have a phenomenal impact on your ability to get better. The first aspect of that are relationships, interpersonal and the nature of the relationship you have with healthcare providers, the whole social context in which you live. The second is what I describe with the Greek term dieta, which is the basis for our word diet, but involves not only diet and nutrition, but your whole lifestyle. The third is your environment. And the fourth is a concept called detoxification, which conventional medicine doesn't really have a good handle on. And that's the ability of your body to purify itself and rid itself of toxins. The GI tract is a very important source of toxicity and also a very important area for the clearance of toxins. And so I review my experience. There are a lot of case reports in there, some of them pretty dramatic. There's practical advice, and there's a look back at the history of medicine and how these concepts came to be ignored because they were well understood in Hippocratic medicine, well understood in terms of the science available at that time, and came to be ignored in conventional medicine and are now being restored to the place that they deserve in the healing process. And every alternative practitioner I know who is good at what he or she does, whether they do it consciously or not, applies those 4 pillars to the care of their patients.
Excellent, excellent. Well, Dr. Galland, I know you have to run, so I just want to thank you again for your time today. It's been a real honor to pick your brain and learn from your experience. And I also want to thank you for all the work that you've done in the world of integrative medicine. I know it's going to help a lot of people and give more power back to the patient. So thank you so much.
Okay, well, thank you for getting the word out there, because there are a lot of people with IBD that are suffering and can be helped by understanding the way they can use nutritional therapies to benefit their condition.
All right, well, thanks for listening today. If you enjoyed what you heard, make sure and go over to iTunes and give us a rating. Let us know what you think and share the love a little bit. This has been Jordan Reasoner and Steve Wright with the SCD Lifestyle Solution Podcast 29.